Hi, I'm Mohammed Jahanzeb. I'm a medical oncologist in Boca Raton, Florida. I focus on lung cancer and breast cancer, and I work with Florida Precision Oncology, a division of 21st Century Oncology.
Hi, I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C.
I'm Michael Lanuti. I'm a thoracic surgeon at Mass General Hospital. I'm the director of thoracic oncology in our division of thoracic surgery, and I'm an associate professor at Harvard Medical School.
Hi, I'm Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I am chief of thoracic radiation oncology and stereotactic body radiotherapy and director of clinical trials.
Hi, I'm Michelle Ginsberg. I'm a radiologist and I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center in New York City.
So very, very briefly, this is an 80-year-old male, a very fit gentleman with a history of hypertension. He had a history of non-Hodgkin's lymphoma and had radiation only to his neck at the NIH in 1982. He presented to the emergency room with fatigue and slight cough and shortness of breath. He's got a performance status of 1, even though he is 80 years of age. So as mentioned, he has a past medical history of hypertension, non-Hodgkin's lymphoma, and did receive radiation to his neck at the NIH in 1982. He is a never smoker. His family history is consistent with a brother with pancreatic cancer. So the CT scan revealed a mass, and I hope we have images of this, and maybe I can just stop there and have Dr. Ginsberg discuss some of the imaging that was found.
Yeah, so we see the lingular mass, which measures 2.9 by 1.5 centimeters. And on the adjacent PET CT, we see that the tumor is FDG avid with an SUV of 5.1. But additional to the hilar lymph, there's a hilar lymph node on the right side, so the contralateral side, as well as some mediastinal lymph nodes in the paratracheal region.
Yeah. So parenthetically, he had his CAT scan on the inpatient side, and then we ordered the PET scan on the outpatient side after we got a biopsy. So the patient did have a CT-guided biopsy of the left mass that confirmed NAPSIM positive, TTF1 positive adenocarcinoma. As all of our patients, except for patients with a peripheral T1, and also because his PET scan lit up in the mediastinum and in the right hilar, which is the contralateral lymph node on the other side. An EBUS was performed to assess both 4R and 11R. Remember, the lesion's on the left, and both were positive for adenocarcinoma. As discussed before, we do send, especially for our 3Bs, and we can talk about the staging here, but this patient, we did send for molecular markers and PDL1. His PDL1 was 90%, and his ALK rearrangement was detected by FISH.
So tell us what you did, but before you go there, let me ask Dr. Robinson, since you said specifically that at your institution you would not send next generation sequencing in non-metastatic disease, how would this case be managed at Washington University?
Yeah, no, and I think it belies the point about just where we're going with this and why that might not be a inappropriate thing to do. So this patient has pretty extensive contralateral adenopathy. It's a stage 3B disease. Obviously we would complete that with a brain MRI, and assuming that was negative, then it becomes a question of is this patient really a candidate for so-called definitive chemoradiotherapy? The challenges of trying to deliver chemoradiotherapy in a patient like this is that a considerable amount of their lung and mediastinum and esophagus is going to receive upwards of 60 gray of radiation. Now we have obviously many different fancy ways of delivering that treatment with various forms of X-ray or proton radiotherapy, depending on where you live, but it doesn't take away from the fact that anatomy is anatomy, and so toxicities would be considerable here. I'd also say that when we see a distribution like this, we have to be exceptionally concerned that this represents really the tip of the iceberg, and there could be other occult metastatic disease that is below the limit of detection of the PET scan. And so this is a scenario where you'd have a really comprehensive discussion with the patient, talk about their overall fitness and performance status, and whether they would want to proceed with a course of definitive chemoradiotherapy, or more likely, perhaps start with some sort of systemic therapy and then consider consolidating with radiation down the line.
So again, I'll be provocative, and since you mentioned systemic therapy, even though I'll get to Dr. Levy about that, being the medical oncologist, but if you found out the patient had an ALK rearrangement, would you ask for some targeted therapy as systemic therapy, or still go the conventional route with chemotherapy?
Yeah, I mean, I guess I would really have to defer to my medical oncologist on that. I would say that, we probably would be somewhat blinded by that data since we wouldn't necessarily have it. But if you knew you had an ALK rearrangement, it would be certainly, as a non-medical oncologist, I would just say that based on my experience with these patients, it would be quite tempting to want to use that. I think the challenge would be that it becomes less clear. With a course of platinum-based chemotherapy, there's a beginning and an end to that series of treatments, and then we would then consolidate with treatment after that. So we would offer a sequential approach. There's less of a clear beginning and end when you initiate something like an ALK inhibitor. And there also is an increased risk of adverse events when trying to combine small molecule TKIs and radiation that we've published and others have seen as well. So it's something to be cautious about.
Great. Let's ask Dr. Levy what he did.
Yeah, I think a couple of things. This case is interesting and highlights the importance of medicine as an art versus a science. It also highlights the importance of, getting all information, remembering that genotypes usually take precedence over PD-L1 in these patients. Unfortunately, I think Dr. Robinson did a beautiful job summarizing sort of how to approach this, even from a medical oncology side, and all the challenges that exist when we're making these decisions. We have zero data for ALK-directed therapies for stage 3A/B lung cancer, and we must extrapolate in the advanced stage setting. And I think at the end of the day, I did exactly what Dr. Robinson had stated. I referred this patient to the radiation oncologist, and had at least a discussion between the radiation oncologist and the patient about the field, the toxicity, the challenges. But at the end of the day, we ended up giving this patient an ALK-directed therapy. And Dr. Robinson alluded to some of the challenges. How long do we do this for, number one? Number two, do we think about consolidating with radiation at some point, given that ALK-directed therapies generally, or any TKI for that matter, aren't generally considered curative? And so I think we're still, we're in the beginning stages of our decision of initiating alectinib, again, based on very limited data. I think we need to remember there's a retrospective analysis that just came out last year in the JTO showing the median life expectancy for a stage 4 ALK patient receiving ALK-directed therapy is close to 7 years. That's not months, that's years. This gentleman is 80 years of age. So we are implementing ALK-directed therapy for now, but I think there's still question marks for how long, and then is there a role for consolidated radiation at some point?
And I think it's probably worth mentioning that by comparison, the literature we have for a stage 3B treated with definitive platinum-based chemotherapy and radiation is closer to, median survival of maybe 2 years. So there's a big difference there.
Yes, the other question that comes up here is if the standard of care is specific trial, like you said, i.e. immunotherapy for a year after definitive chemoradiotherapy. So on the one hand, not giving this patient immunotherapy is a breach of standard of care, especially with such high PD-L1 positivity. On the other, we know the truth about immunotherapy in ALK-altered tumors. So you want to comment on that?
Yeah, I think that, again, extrapolating retrospective analysis coming out of France, published in the Annals of Oncology, I believe last year, originally presented at ASCO in 2018, showing large retrospective analysis looking at single agent immunotherapy for multiple genotypes, EGFR, RET, ROS, and also ALK. And the bottom line is in this retrospective analysis, the single agent activity of immunotherapy for ALK-rearranged lung cancer at an average line of therapy of 3 was around 3%. The response rate was around 3%. So there's very little activity, at least with single agent immunotherapy. Now, whether PD-L1 makes a difference or not, we're not really clear in these genotypes. We have some data, of course, in the EGFR setting to suggest it doesn't. But the rule of thumb is single agent immunotherapy generally is not that efficacious for patients with ALK-rearranged lung cancer.
So you would not give durvalumab to this patient, even
I
after
wouldn't.
consolidating with radiation?
No, I wouldn't. I would ride out the TKI for a while. I mean, as you know, we have a lot of other TKIs that are coming down the pike every other month that are ALK directed. And so I would avoid immunotherapy. And the rule of thumb for ALK-rearranged lung cancer, the question also is a 3B that different than stage 4? And that's a question that I think Dr. Robinson alluded to, is the PET just missing some of the things that are micro-metastatic that we may not be seeing. But the rule of thumb is to try to sequence these patients on ALK-directed therapy. So I would do that and avoid immunotherapy, with still the caveat questions being, how long do we do this for, and is there a role for radiation at some point?
Yes, and Dr. Robinson also alluded to a very important point, that with ALK-altered tumors, having a predilection for brain metastases, that a brain MRI is a must in this case, up to, I would say, 40% of patients would have brain metastases at the outset, and maybe 70% plus in the course of their illness.
Yeah.
So that would be another area to look for before doing anything definitive in the chest. Would you agree?
Absolutely. Yeah. I mean, we know the incidence is high. We also fortunately know that, I guess, with these newer generations of drugs, there's increased CNS penetration compared to earlier ones. And, as a radiation oncologist who also treats brain metastases and uses intracranial radiosurgery, I've been often astounded at some of those responses. So
this has been a truly enlightening discussion. I thank all of you. These were phenomenal cases, all requiring multidisciplinary input, and it's such a treat to have world-renowned experts discussing them and coming to a consensus. Thank you all.